Thank you all. Great talk, great start, Matt. My goal is to give you an overview, possibly a clean phenotype of drug-induced liver injury that we can all extrapolate to this area, and the hassles when it comes to attributing causality to the implicated agent and things like that. I'm one of the hepatologists at IU. Okay. Okay, thanks. The outline of my talk, I want to briefly go over the intrinsic type of liver injury versus idiosyncratic drug-induced liver injury, some risk factors for DILI, genetic basis for DILI, how do we diagnose drug-induced liver injury, some special considerations such as drug-induced autoimmune hepatitis, some dietary supplement-induced liver injury. This is a big deal right now in both the academic world and the main street. Some atypical liver injuries, not always liver injuries associated with elevated liver tests. Sometimes it causes vascular injury, and it is hard to recognize if we stick to conventional ways of identifying liver injury. Sometimes liver injury can happen in patients with the underlying liver disease, and there's always a conundrum with regard to, is it a flare-up of underlying liver disease, or is this drug-induced liver injury? And lastly, I want to bring to your attention a very good resource called LiverTalks that is from NIH. Drug-induced liver injury is basically two types, which is intrinsic. Classic examples are acetaminophen and chemical toxins. So if we are talking about environment-induced liver injury, maybe we have to think in terms of intrinsic liver injury. This is predictable, reproducible, maybe dose-dependent all the time, and then there is a characteristic histologic change. Idiosyncratic is unpredictable, may lack a strong dose relationship, and the liver injury may not be same all the time. So idiosyncratic is what we deal with as clinical hepatologists, where patients get drugs, not everybody gets the same type of liver injury. I want to take you back to the intrinsic drug-induced liver injury, which is the acetaminophen classic example. You have the overdose, the intrinsic mechanisms of metabolism are overwhelmed, the toxic metabolite is formed, and there is glutathione depletion, and this results in covalent binding, oxidative stress, hepatocyte damage, and there is a characteristic liver injury which occurs around the central vein. So it is pretty obvious. Patient gives the history, liver enzymes are markedly elevated, and if we end up doing a liver biopsy, you see a characteristic change. There is an antidote to deplete the glutathione to help this to stop this pathway and to make the pathway go towards excretion. Now, idiosyncratic drug-induced liver injury, the challenges are many because it is very uncommon, it is difficult to predict, it is difficult to diagnose, and we don't have any standard of care with regard to treatment. And also, as I said earlier, it can occur in patients with underlying liver disease. Epidemiology is very important because it is often underreported and underestimated. Incidence is unknown, possibly because we as hepatologists see the number of cases if we are lucky, and it is recognized, but we never know the real number of prescriptions. So without a good denominator, we can never really figure out the incidence. There are some population studies, especially small countries like Iceland, where it is universal healthcare system, everybody knows everybody sort of population. They've figured out maybe 19 cases per 100,000 per year, so it is very uncommon. But it may be different for different drugs. Augmentin, which is very common, it probably is the most commonly prescribed antibiotic in US and one of the top offenders for drug-induced liver injury. Then there is diclofenac, some biologic agents, and nitrofurantoin, number one prescribed drug for urinary tract infection by urologists. One has to understand that what the piece that we are trying to do has to fit into the greater scheme of things. There are many things that can lead to drug-induced liver injury. Some may be related to the drug, some may be related to the environment, some may be related to the host, or oftentimes it's a combination of all these three. So if one is trying to figure out that DILI is all related to immune factors, maybe we're not able to answer all the questions because everything else has to line up before this mechanism is in play. Some of the questions that we try to answer from our group include the drug properties and the risk of drug-induced liver injury. First paper we looked at was relationship between daily dose of oral medications and hepatic adverse events. We picked up top 100 prescribed drugs in US, and we looked at the package insert and their labeling from physician drug reference, and we quantified their adverse events based on their dosage. And we saw that as the dose increased, dose per day increased, the risk of adverse events increased. So maybe there is some truth to drug dose and idiosyncratic drug-induced liver injury. We again looked at this separate question where if a drug undergoes hepatic metabolism, there is a more chance of forming a drug hapten complex eliciting an immune response. So do drugs that undergo metabolism cause more higher liver problems? So this study, we looked at drugs, quantified drugs as undergoing greater than 50% metabolism, and we saw that a significantly higher frequency compared to drugs with low metabolism. ALT greater than 3 times, this is one of the things that FDA looks at in a phase 3 trial before they go through approval process, 34% versus 10%. Liver failure, 28% versus 9%, transplantation, and fatal DILI. But if you look at just jaundice, it was not statistically significant. Pathogenesis of DILI is very complex. This is just after the injury occurs. These are the steps, but before the injury occurs, I'm not representing on this pathway. But it could be initiation that could lead to primarily reactive metabolite formation. This could be CYP450 mediated bioactivation, glutathione depletion, oxidative stress, covalent binding to protein. But after the injury occurs, it may be mostly host response with regard to perpetuation and ongoing injury. That is related to mitochondrial injury, intracellular stress, sensitization, immune response. And the pathways of injury are mostly necrosis and apoptosis. And then host-mediated immunity, which is adaptive immunity or TLR response stuff with natural killer cells activation and perpetuation of liver injury. We are currently looking at HMGB1, which acts as a damp in mediation to TLR causing liver injury or fatty liver-related liver disease. Some of the work that is being done in the past, this is a compilation table, genetic basis looking for drug-induced liver injury. Drug disposition genes often make sense. So some drugs that undergo metabolism, some of the CYPs have been implicated with regard to polymorphisms in those genes causing drug-induced liver injury. One has to be cautious in interpreting this data. Some polymorphisms are particular to some patient populations. So some study from China may not be relevant to population in US. If we were to look at host response, then HLA makes sense, and many drugs have been implicated with regard to HLA polymorphism and the risk of drug-induced liver injury. This is again a compilation of table, different polymorphisms with regard to HLA. And again, my summary, my understanding of this field is it's hard to replicate a European polymorphism in a US population. And often the answer is, well, your sample size is not enough, and I don't know how big the sample size needs to be before we break the bank to figure out whether it is truly correct. But a lot of work has been done, especially from NIDDK and Drug-Induced Liver Injury Network. One of the papers that's out this month is our work with regard to, does the drug properties influence the severity of liver injury and outcomes related to liver injury, because our prior work looked at drug properties and risk of liver injury. So we looked at the relationship between drug characteristics and DILI phenotype with regard to type of injury and outcomes. These are the patients that were enrolled in the Drug-Induced Liver Injury Network with good causality assessment that have been vetted out, and all the information available with regard to outcomes and characteristics. So we looked at first 50 milligram per day dose or lower, and we saw that the difference between the time to liver injury, pattern of liver injury, time to peak ALT, time to recovery, hospitalization, liver-related death, and transplant were not statistically significant. Similarly, we looked at hepatic metabolism, and none of the outcomes were different. We also looked at the characteristics of drug based on their permeability, solubility, metabolism, based on the biopharmaceutical classification, and we did not see any differences with regard to clinical outcomes. The only difference we saw was pattern of liver injury was slightly different, but really clinically didn't make much of a significance. So based on this work, we think that maybe the drug properties may decide the risk of injury, but once the injury happens, it's the host who decides the outcome. We also did look into serum proteomic profile in people who are who have drug-induced liver injury. We used label-free mass spec, 74 drug-induced liver injury patients, blood collected within 14 days of liver injury. So these were like hot cases of liver injury, 40 controls, and we had follow-up data 6 months later on 21 patients. So we were able to do global proteomic study, and we saw this is with regard to type of liver injury. We saw 25 proteins that are differentially expressed between the type of liver injury. And as you see, most are related to acute phase proteins, complement system, coagulation system. And we also saw if any of the proteins were different between baseline and 6 months. And these were related to acute phase proteins, oxidative stress, hepatic steatosis, cell death, steatohepatitis. And of all these proteins that were elevated at the time of injury, all of them normalized at 6 months. We then compared with regard to controls, and we saw that the proteomic profile that was significantly different between controls and patients with drug-induced liver injury were again related to complement system, inflammatory response, cell death, coagulation system. We then looked at which protein will help us recognize drug-induced liver injury from controls. And ApoE is the protein that popped up with around 87% diagnostic accuracy when we are trying to recognize a case of DILI from controls. And this is the ALT, which is around 73%. So the critique from the reviewer was, well, this is just controls. The real question is, in any other acute liver injury, can you differentiate drug-induced liver injury from that? So in the future, we will plan on doing that, but the study design of DILI does not enroll controls or any other liver disease. Clinically, slight switch in the gear to help you understand the hurdles of identifying these patients. Most of the times, the patients may be asymptomatic. There may be just liver enzyme elevation, and by the time the PCP sees, primary care physician sees for the second visit, the liver enzymes may already normalize, and there may not be much incentive for them to go and look and find the implicated agent because patient is already normal. Sometimes there may be systemic symptoms. So these include very vague symptoms such as fatigue, itching, pain. Sometimes there could be an immune reaction such as fever, rash, and eosinophilia. And if the liver injury is very severe, you could have jaundice, coagulopathy, ascites, and liver failure. Some drugs specifically cause vascular injury, especially the newer biologic agents. Most of the new cancer chemotherapeutics, you have to understand that they work in different mechanisms and not fit in the traditional drug-induced liver injury concept. And then fulminant hepatic liver failure needing a liver transplant. And as elaborated in this table, there's a plethora of presentations. Not every drug causes liver injury in a similar pattern. Some drugs cause characteristic patterns, such as anabolic steroids. We are seeing a lot of young patients getting sold at the gyms with some supplements that they buy on the internet. It's peer-to-peer marketing, and they have a lot of anabolic steroids, and they get severe jaundice but normal AST/ALT. And their jaundice peaks up to bilirubin 50, and they're already panicking whether he needs transplant or not, but the INR doesn't budge. So oftentimes when it comes to clinical, it's a diagnosis of exclusion. We have to look into temporal relationship. We have to know what happened after the drug was discontinued. Does the pattern fit in with the prior reported pattern? Is it a known hepatotoxin, and was there any re-challenge? It's almost like a crime scene investigation, a lot of work. You have to call the pharmacy to get the list of drugs. Patients don't remember the dates. And the scenarios could be different. You may be involved when the drug-induced liver injury is happening, and it's very easy. The patient may be on the drug or tells you that he was on the drug recently, and it's a very simple scenario. Or the latency period could be 2 months, and patient may not remember with regard to taking the drug. Or things happen, not recognized, and inadvertently re-challenged the second time, the severity of liver injury may be even worse. Temporal relationship is very important. Some drugs cause liver injury within 5 days, some cause within 3 months. So these issues need to be considered. Some typical drugs, sulfonamides, antibiotics, short latency, INH, nitrofurantoin, amiodarone, these are long latency. We've had some women who came to us with cirrhosis for being on nitrofurantoin for 4 years before it was recognized that it eventually caused liver failure. When the drug is stopped, the improvement may be very rapid, and it makes us think that maybe that was the implicated agent, but sometimes it takes several weeks, and we are questioning, did we make the right diagnosis, or is something else going on? Sometimes the recovery may be prolonged. It takes more than 6 months. That currently qualifies for the definition of chronic liver disease. And the pattern of injury, sometimes it's predominantly ALT, sometimes it's predominantly biliary injury, which causes alkaline phosphatase injury. So this equation that we use, it's patient's ALT divided by upper limit of normal, the whole thing you divide again with this ratio. And if R is less than 2, this is cholestatic. It helps us recognize that there's a biliary process, fits in with anabolic steroids. Or if it is a hepatocellular, we think it's an INH-like injury. And some drugs cause, immunoallergic hepatitis, rash, fever. This is more maybe HLA-mediated injury, short latency, and then you have DRUS syndrome, which is nephritis, hepatitis, skin rash, and the whole global adverse event. Workup is usually having a high index of suspicion, careful history, alcohol use. There's some question with regard to, does having alcohol increase the risk of drug-induced liver injury, or being obese, having fatty liver, increase the risk of drug-induced liver injury? In fact, 3 months ago, FDA had a symposium, and they asked me to come and talk about, does having fatty liver increase DILI? That was the topic, and there's really difficult to answer that question because there is no data. The only association we found was if somebody had diabetes, potentially they may be at increased risk, but then questions come, is this polypharmacy? Are they on so many medications? Who knows what sort of situation? Lab and imaging, unfortunately, it's still blood work to exclude competing etiology. There's no diagnostic test for drug-induced liver injury. And some of the pitfalls we have to avoid, sometimes we end up enrolling acute Hep C as drug-induced liver injury because Hep C antibody is part of the hepatitis panel, but not hepatitis C viral load, and antibody takes 4 weeks to turn positive. So you have to have a Hep C viral load to exclude acute Hep C, and just antibody is not enough. There is increased awareness with regard to hepatitis E. Classic example is pregnant woman in India gets acute hepatitis and dies. That's Hep E, textbook example. But now it is recognized that it is quite prevalent in United States. It is mostly a zoonotic infection with different genotype from swine. There is some association with hepatitis E and INH-induced hepatitis. Does having hepatitis E increase the risk of INH? That's being looked at, but there is some data. So there is some interaction between environment and drug-induced liver injury. Often a biopsy is done, but it is not required to make a diagnosis. It may serve as a prognostic tool. If we see a lot of necrosis, then we know that the outcome may not be good, and we may plan on working up for liver transplant. Some drugs cause a different type of liver injury that may not be all related to ALT elevation. So if we go to LiverTalks, they define an agent in different ways with regard to whether you think it's a hepatotoxin or not. Category A is a drug is well known, well described, well reported to cause either direct or idiosyncratic liver injury. Characteristic signature, more than 50 cases, including case series, have described. So there is a good confidence if you are implicating this agent as the cause for liver injury. But if you look at category E, despite extensive use, no evidence that drug has caused liver injury. Single case reports may have been published, but they were largely unconvincing. So when we review the literature and we look at a case report from 1985, and we think that's the drug that's causing, but Hep C was only discovered in '89, and the test to check it came out in '91. So that case report, for all that matters, could be related to Hep C, and it was published as a case of drug-induced liver injury. So one has to be very careful when interpreting the data with how much clarity the case has been published. So LiverTalks, I'll talk about it. But with regard to understanding DILI, one of the most sentinel features is addressing the causality. If we do not assign causality well, any subsequent genetic studies, any subsequent mechanistic studies may all go waste, because if we are enrolling a case that is not really drug-induced and all the work has been done later on, and you come back and say, well, it was never really drug-induced. So we don't want to include cases that are not DILI. So that's why causality assessment is very important when we are enrolling in drug-induced liver injury. Some of the scales that are available in the literature for any adverse reaction is Naranjo scale, but DILI-specific instruments are RUCAM, M&V clinical scale, causality assessment by expert opinion, and causality assessment that we in DILI use. RUCAM is basically what we do clinically, but giving an objective number to a clinical thought process. They give numbers with regard to temporal association, course, risk factors, concomitant drug, non-drug causes, prior information, re-challenge, and there's a weight with regard to the number. So high probable is if you get more than 8 points. In drug-induced liver injury network, it's mostly an expert opinion. For lack of time, I'm going to skip the process, but at the end of our process, we define the case as a definite, very likely, probable, possible, unlikely, based on these factors. And for all genetic studies, mechanistic studies, we only use the serum or biorepository samples from definite, very likely, and probable. We do not use possible or unlikely. And when we compared our DILI expert opinion to RUCAM, they stand pretty good. So if you're not part of DILI and you don't have access to expert opinion, you may as well use RUCAM. So this is the Drug-Induced Liver Injury Network. It's a UO1 consortium. It's a prospective registry of patients with bona fide DILI for future studies of host clinical, genetic, environmental, and immunologic risk factors that would precipitate drug-induced liver injury network. More than 1,200 cases have been enrolled as of now, and 800 or more have undergone causality assessment. A hot topic right now, as I said, is herbal dietary supplement related liver injury. This paper came out this month. Our paper came out from DILI this month, and already lawyers are calling, CNN wants to do a talk, and things like that, and a lot of heat for publishing. So dietary supplement, any product intended to supplement diet may contain vitamins, minerals, herbs, amino acids, or extracts thereof. They don't have to get FDA approval, as everybody knows, but the burden of proof that the product caused harm rests upon FDA. And these are some of the FDA warnings that led to recall. The most recent was Oxy Elite Pro, rash of cases from Hawaii resulting in acute liver failure, all of them related to taking this Oxy Elite Pro. And it was CDC that was first published and raised concern with regard to that. And there is Hydroxycut, that was the weight loss supplement that was recalled. It's back again in the market with a different formulation. So this is the temporal association that we published from the DILI. In 2004, 2005, there was 7% of the cases that we enrolled were HDS-related liver injury. By 2012, it was 20%. Either it is prevalence or is it increased awareness from the investigators. You know, whatever it is increasingly recognized or it is increasingly common. Some of the agents include, stuff for bodybuilding, weight loss, depression, and other things. The outcomes were a little bit different with regard to bodybuilding. People never really needed liver transplantation, but non-bodybuilding supplement people ended up requiring liver transplantation. So we use this data sometimes to postpone the liver transplant workup. So some of the lessons that we learned from DILI are multiple agents. People come with bags of supplements and we don't know which one caused what. Is it the product that is on the label that caused the injury? Is it the product that is on the label that is not the same amount that caused the liver injury? Or is it a contaminant in that bottle that caused the liver injury? Nobody knows. We have to worry about other causes such as Hep C, Hep E, and stuff like that. And somebody was saying, is it all ALT? It's not all ALT. We have drug-induced vascular type of liver injuries. ALT is often less than 3 times the upper limit of normal, and the liver injury can occur more than 6 months later. And by the time they present with portal hypertension, meaning ascites, bleeding, but no hepatic dysfunction. And these are the typical drugs, most of the chemotherapeutic agents. So if we have to extrapolate to the environment, there may be some gold, penicillamine, some stuff that could, Thorostat, we may be able to see in environmental toxins. Then the question comes with regard to DILI in patients with liver disease. Patients with liver disease already have ramped up oxidative stress, inflammation, may have compromised pharmacokinetics, enzyme activity. They may result in decreased regeneration, increased fibrogenesis, and there was concern with regard to using statins in patients with fatty liver. methotrexate in fatty liver, and INH in hepatitis B. We have a lot of Burmese refugee population in Indianapolis all of a sudden, and they have Hep B, they have latent TB, and we are faced with this question, what causes what? So if somebody has hepatitis B with high replication, they are at increased risk for INH hepatotoxicity. So we treat their Hep B first and then treat their latent TB. Lastly, LiverTalks. Jay Hoofnagel at NIH has taken a lot of work, has put in a lot of effort trying to harness all the information from DILI and develop this website and summarize the literature instead of you going and searching for case reports. He's done all that and put it at one place. So I recommend going to livertalks.nih.gov. It gives you what the drug is, what kind of pattern the injury would happen, a case report, so you can identify whether your case is similar to that, and you have an opportunity to submit a case. You don't have to review any literature anymore. So lastly, DILI is a diagnosis of exclusion. There's questionable value with regard to signature. Genetic associations may be drug and population specific, but need to be validated. Many of the issues that I have not discussed today are inclusion-exclusion criteria for enrollment. There's a retrospective study, causality assessment process, minimal criteria for publication of a case of DILI. We said any time in the future, if somebody wants to publish a case of DILI, these are the minimum things you have to include in your case report, because we don't want unnecessary information to be published which is not of use and only confuse the readers. Then there's a DILI severity score, and then there are a lot of ongoing mechanistic studies, but they are not published yet, so I can't talk about it. Well, from far, it may appear that, I'm here, I'm going to go find a fish, and it's going to be very difficult to find that fish, which is drug-induced liver injury patient. But if you know how to look for, it's very easy. These are some pictures from my recent trip to Alaska. You just stand where the fish is swimming upstream. You just catch like anything. So these are all the people lined up to catch salmon going upstream. Well, thank you. Any questions?
I had a question, Raj. So are there any lessons that you can think of that have been learned through DILI that could be applied to occupational and environmental liver disease? So say I have a patient that comes from a chemical plant, or somebody that's eating the wrong contaminated corn that it has some type of liver injury. Is there any approach that you can recommend that may be applicable? Do we do a ROCAM score, or I don't know if you had any comment?
Well, it should start off with defining the phenotype and everybody agreeing that that's the phenotype that we're going to enroll. We don't want to enroll mild elevations in ALT or non-clinically significant liver injury patients. So first defining the phenotype and establishing the criteria are very important. And I think causality will be depending on what phenotype you want to find. And it may be very difficult. At least in DILI, all we had was 2 successive ALT elevations that are greater than 10 times or bilirubin greater than 3. That was simple. And non-Tylenol, non-transplant. So, thank you.
Very much.